Okay, guys, good morning. This is Dr. Bashura. I'm from the Greater Houston Oral Surgery Group. I'm going to run you guys through a case. Um, the reason why we're doing this is I do realize that, a lot of times when our patients comes to see us, we have 15, 20 minutes to spend. We talk about a lot of things, and a lot of things are not clear. People don't understand why we're doing it. A lot of times people, because they don't understand, they may end up making decisions that are not in their best interest, or decision based on the lack of understanding and just emotions and figuring out like, well, this is expensive, I don't want to do this. And I'm hoping today that we will talk about what all the little details mean, and we'll talk about some codes. I think it's going to be a very informative, and I hope you guys find this informative, so please let me know what you think. I'll start off with this. This is a 50-year-old lady who just has a beautiful smile, and her smile is very, very high. So meaning when she smiles, she actually shows all the teeth, all the gum here. So managing this case was very, very important. And this lady had actually a bad tooth here. Okay, this tooth was gone. The crown broke off, and we decided to take the tooth out and do what we call an immediate implant here. And so I'm going to show you a lot of bloody pictures. I hope you guys are okay with this. I think it's important to show these because it gives you understanding. But just want to warn you that there's a lot of bloody pictures here. If you're uncomfortable, please don't watch this, or just be sure that you've been warned. All right, so perfect. So moving on. So this is the procedure itself. We obviously do this under anesthesia, so patient is comfortable, doesn't remember anything, and this is after we've numbed the patient up right now, and of course she's asleep. So the crown broke off, and as you can see here, there's really not much left to the root, to the tooth itself. And unfortunately, these are kind of scenarios that are where the tooth just simply has to come out. There's not many solutions to do this, to fix this. And as you can see right in this area, there's a lot of decay here, a lot of stuff going on, so really not much we could do. And so what we do really in a scenario like this, and this is an ideal case where we go in, we take the tooth out, and we do an immediate placement of a dental implant, and I'll explain everything to you as we go along. So the first step is we actually will remove the tooth first, but at the same time, a lot of times I'll go in there and I'll actually remove the gum off the bone just to see how much bone there's underneath all this, and so you get to see a little bit of that. So here's after we're done removing the gum off the bone and we removed the tooth. Let me go back here. We removed the tooth, obviously removing this in an atraumatic fashion. What that means is we try to remove the tooth, and in this case I actually sectioned it here and removed it, and we do not want to lose any bone in the removing process. This is very, very important. We have very nice healthy bone. You could see a nice healthy layer of bone right up here. This is very important that we have this much bone here. Otherwise, the procedure was going to change. Depending on what I'm going to do during surgery is going to change. But this is very nice, healthy bone layer. And then what we do, the next thing we do is we really start, kind of drilling for the implant. And this is what we do is, we drill a hole into the bone. And this is an angulating pin. I put it in there after I do my first drill to make sure that the implant will be centered and that the implant comes out in closer to the palate than the cheek, the lip area. And this is very, very important. I'll show you why we're doing this. And then we go ahead and place the implant. What you're seeing here, you see, I want you to be aware that the implant goes on the palatal aspect here, closer to where the tongue area, not towards the cheek, and you'll have a space between the implant and the bone, and you have to fill this space with bone. This is very, very important. Otherwise, you have a lot of bone resorption. the bone goes away, it doesn't heal well. So almost always when we do these immediate implants, it is extremely important that we actually put bone in there to regrow all the bone that you lose. And I'll show you pictures of what that looks like. This blue part here, this part here is the implant mount. It's how we put the implant into the bone. We use this mount. We try not to touch these implants when they go in. It's very, very important that nothing touches the implant. And what we do then, and this is another picture showing the angulation of the implant. And I want you to notice in this scenario, I want you to notice right in here, the implant actually, because we wanted to have a certain angulation of this implant, right in here, the implant actually comes through the bone. And you really want to graft this area. You want to add bone back in there. And I'll show you how we did that. So moving on. We take this, well, I'll go back. This mount here, this mount actually comes off. This is the mount that we actually use to put the implant in. It comes off, and then we actually put a little screw to cover the hole. So this is called a cover screw right here, and it covers the implant so bone doesn't grow inside the implant. So because we're gonna have to retrieve this thing later. Again, I want you to pay attention to this area. There's a lot of space in between the implant and the bone, and that all has to be filled in. You can't just leave that there, otherwise we'll lose all this bone, and then you're gonna start seeing grayness and the area is gonna look super ugly. So this is very, very important. Anytime we do an immediate implant placement, every time we do that, we have to graft. And so, you know, there's grafting that's done. This is showing you the reason why I'm showing you here. This is an example of a temporary tooth that we did. It is very important that the implant is angled in a certain position so the screw comes out in an area where nobody could see. Okay, this is very, very important. The screw comes out of here, out of this area, so when you put the implant in, and then this area, this hole gets filled with a composite material, and so that's why the angulation seems like it's off, but this was perfect angulation here. Okay, moving on. If the implant is not positioned well, this is the kind of access you'll end up with this picture where the screw hole comes out on really the facial side, and it's very anesthetic, and you have to fill that in, and sometimes it breaks off, so it's just a mess. You really want the screw to come out in this area right there on the cingulum so nobody sees it, and that's why the angulation is off. So I hope that explains it. Very good. Moving on. And this is a picture of the graft, and the graft is really basically what we use in our practice. We fill the void. We fill it in here between the implant and the bone, and remember we had an implant coming through. We filled this area here as well, and this is important. This is human cadaver bone that we use, and it's mixed with this patient's blood. And the idea behind it is that the bone cells will come from the bone, and they'll grow into the graft here and into the graft here. Okay, and that process takes about 4 months, so it does take a very long time. But now this powder is just human calcium from somebody who is a donor. And it has no tissue in it, so really we depend on your own cells to grow into this graft. This is very, very important, and I'll explain something to you in the next slide here. I'll explain something to you here. So in order for the bone, and you can see this is another picture of the graft that we put in there. Now it is important that the bone cells, they grow from the bone that's alive into this bone that's not alive. Now there is kind of a fight for growth, because the soft tissue that's up here, the soft tissue also wants to grow into this graft. So you have to isolate this bone from the tissue, and the tissue typically heals much, much faster. And so you wanna guide the bone cells from the native bone into this grafted bone to heal, and you want to prevent, you have like a little barrier to prevent the soft tissue cells to growing into this bone here. So and this is what we call guided bone regeneration, and what it looks like is like this. We put a little membrane there. This membrane is a biological membrane. It's cross-linked collagen, so it prevents tissue cells, so it blocks the tissue from growing into the graft, because you want the graft to be grown with bone cells, not tissue cells, otherwise you won't have good bone. And so this is what you call guided bone regeneration. We're guiding the bone cells to grow into the graft, from the bone into the graft, and we're preventing soft tissue cells from growing into the bone. And this is what, when you hear people say GBR or guided bone regeneration, that's what they mean. And this membrane is actually fairly expensive, so a lot of times you'll see a charge for this, and the code is 4266 for this. So you'll see a code for membrane, and right in here, this is actually a little titanium tack. It's basically a little titanium nail that we tap the membrane, and we hold, so it doesn't move, because if these membranes, if they move around, this whole thing will get infected. So that's why it's important for these titanium tacks to be there. A lot of times I use titanium tacks to hold the tissue in place. Moving on, and then we suture everything up. Okay, we suture everything. One thing I want you guys to notice, these stitches come out on their own. Down here, these come out on their own. This is a different type of suture that we'll have to typically remove after 2 weeks, and I'll show you what that looks like. So these come out on their own. They typically fall off in about 4 or 5 days. One thing I want you guys to notice is, there's two types of tissue. There's a movable tissue, okay, which is right in here. This is movable, meaning when you pull it, it moves. And this is what you call unattached tissue. Let me remove all this. Now, this tissue here is attached tissue. And for this patient here, she had a lot of attached tissue. It's very, very thick. This is what you call a thick biotype. Typically, patients like this, you could be the worst surgeon in the world, and they still will heal very, very well. You can throw anything at a thick biotype patient. And you could literally be very poorly skilled, and you still have very, very nice results. Now, if you don't have a thick biotype, if you have what we call a thin biotype, a lot of times we end up having to do connective tissue graft. Connective tissue graft, meaning we actually thicken the tissue, and we typically take it from the palate. The tissue is taken from the palate, and we'll do the grafting at the same time. Her dentist is an excellent dentist. It's a dental group called the Dentistry. They're here in Cypress. I will link them below. They made an Essex retainer. Essex retainer is basically a bleaching tray with a fake tooth in it, just so the patient can wear it in the first few weeks. And it looks very nice, very aesthetics. People don't even realize this looks like an Invisalign tray or a bleaching tray. People don't even realize that you're missing a tooth for cosmetics. And then, like I said, the healing time is roughly 4 months, and we bring the patient back after 4 months. And this is an X-ray of the implant we placed. As you can see, there's no darkness around the implant, which is a very good sign. Typically, darkness around the implant meaning the implant did not integrate. The implant undergoes something called osseointegration, meaning the bone cells will integrate to the titanium, and it becomes very, very strong. It becomes part of the body. As you can tell here, there's even bone growing over on top of the implant, which is very nice to see. And again, this is at the 4-month mark. At that point, the bone cells have grown from the native bone into the grafted bone. And let me show you what it looks like clinically. This is what the area looks like. Very nice, healthy tissue. Thick. This is attached tissue, like I explained, very thick. This is also very important to see. Now, if you don't have enough tissue here, what we do sometimes, we'll take tissue from the palate from back here and add some more tissue to this area right there. Again, I didn't have to do this in this case. Patient healed up very nice. She is a thick biotype, so it looks very good. And now in this area, there's an implant down there, so we're going to expose it. And for this person here, the scenario was, well, all we had to do is numb it up, and we did a little, what we call a punch biopsy, a little, a blade that's round punch, and you can see the screw head right there. Sometimes you have to peel off the bone off this thing sometimes. And we take this screw out, it comes off, and what we do is we end up putting something called a healing cap. A healing cap screws onto the implant, and this healing cap kind of heals. This is what you call a healing cap, or a healing abutment is another name for it. Again, this heals for a period of 2 weeks. Then the patient will go see the dentist, and the dentist will actually make the tooth. The tooth that goes on top of this implant is made by the general dentist. So this is what we call implant dentistry part. And again, this patient had a fantastic dentist. And I'll show you a picture. This is kind of I brought the patient back about 6 months after she got everything restored. This is the implant that we did right here. Okay. The dentist will make 2 parts, and I'll show you pictures later. This is called the abutment, this part right here. Okay. This is the abutment, and it's custom made for this patient. And there you can see a little screw right there. There's a screw. It's screwed in, and then the crown, which is made out of porcelain, is cemented on top. Okay. Again, these 2 were done by the general dentist, and I had a great dentist that I work with on this case, and they did a fantastic job. And I'll link their practice below. And that's what it looks like clinically. Again, the laboratory technician did a good job matching the teeth. And you can see the tissue's thick. Again, why is this important? If you don't have thick tissue and you don't do this, or you don't thicken the tissue, almost always you end up with black triangles in this area. These are called papilla. They're very, very important for aesthetics. A lot of times, if you don't have those, or the tissue quality is really poor, you smile and you see a black triangle there, and they're very unaesthetic. Again, we have great results for this patient. And I hope this explains it. I hope this explains the process here. And this is another view. Again, you can't even tell there's a fake tooth in there. But underneath this, if you take an x-ray, it looks like this. It looks like the implant, the abutment, and the crown. But all you see when you smile is this area. Again, I hope this explains it. Here's what a custom, this is not this patient, but here's what a custom abutment looks like. This happens to be zirconia. And again, it's screwed on, and then the crown is cemented. All right, guys, I hope this makes sense. I hope you understand why we're doing, every time we take out a tooth, we're doing bone grafting, and why we need sometimes a membrane for guided bone regeneration. Again, if you have any questions, please visit any of our offices. I'll link them below. We have a lot of locations in the greater Houston area. If you have any comments, please give those, and hit the like button if you like this. Definitely subscribe if you like our channel. And if you want to see any other content, please let us know. Thank you.